Hi everyone. I'm just letting you all in. I'll just spotlight myself. Welcome, welcome. I'm Alex. If I haven't met you before, thank you for coming today to this lunchtime webinar. Just let you all in here. Fabulous. All right, welcome. Good to see you all. I'm Alex Wilson. I'm going to be talking to you today about BPD and CPTSD. A little controversial sometimes, this topic, but I'm glad you can join me. If it's your lunchtime, feel free just to eat your lunch, sit back and relax. But if you have questions or you want to pop in, please feel free to type in the chat or raise your hand and I'll call on you, but I will pause and we'll have some time at the end for a little Q&A as well. All right, let me get these slides up for you. And of course, this is being recorded, so you'll all also get a recording of this in your inbox so you can relive the magic if you want. And there's some people who can't make it live, and I'll send the recording to them too. All right, so welcome. As I said, I'm Alex Wilson. I'm an accredited mental health social worker and the director of Mindful Recovery Services and the Central Coast DBT Centre here in the lovely New South Wales Central Coast, right near Gosford, if you're local. So we're going to talk about this topic, borderline personality disorder or complex PTSD. As I said before, a little controversial. Lots of different views. We're going to unpack it. So, I'm sure you all know and have noticed that borderline personality disorder is more and more being seen through a trauma lens. This is very positive. We know that the vast majority of people diagnosed with borderline personality disorder have a documented trauma history. It's about 80% in most of the studies. So the correlation between borderline personality disorder and trauma is very strong. But this raises the question, and it's a fair question to ask, is borderline personality disorder even a thing, or is it all trauma, right? Is it just always complex PTSD? Now, I say complex PTSD because complex PTSD is, we're talking here usually about childhood trauma, right? Particularly, childhood sexual abuse or, childhood abuse of other kinds. I'm going to kind of get into the definitions in a minute. But we do see a lot of these sorts of presentations in people with diagnosis of BPD. So the question is BPD a thing or is it all trauma? So we're going to sort of explore that. And if they are different, then what does that mean for treatment? Or if they are the same, what does that mean for treatment, right? Does it matter how we're diagnosing these things in regards to how it's informing treatment? So I'm going to sort of unpack that as well. All right, so I'm going to have a look at some of the sort of definitions here or some of the, experiences of trauma. Now, we know that complex PTSD is not an official diagnosis in the DSM-5, okay? But it is recognized by the World Health Organization. So that's where the CPTSD stuff is coming from. But we know with standard PTSD, some of the criteria there are around re-experiencing of the trauma, right? So things like flashbacks, nightmares, intrusive memories, that's all part of what we would consider a standard PTSD diagnosis. There's also avoidance. So this is another core component of PTSD. So attempts to avoid reminders, thoughts, or feelings associated with the trauma. And we often see that in a lot of behaviors in PTSD, like maybe alcohol abuse or other things where people are trying to avoid, and a persistent sense of current threat. So again, that's very prevalent in PTSD. So hypervigilance and exaggerated startle reflex, stuff like that. Okay. When we then have a look at CPTSD, complex PTSD, all those same things apply, but in addition to that, we've got disturbances in self-organization. So we've also got affect dysregulation. So severe difficulties managing emotions, negative self-concept, shame, worthlessness, and defeat. Now, that's not necessarily the case in standard PTSD. I mean, sometimes, but not necessarily. And relationship difficulties, so difficulty sustaining closeness and trust. So sometimes complex PTSD is described as like PTSD plus with these additional features. Now, that being said, I have certainly seen people with standard PTSD who also have some of these things. But are considered to have standard PTSD, maybe war veterans, people like that. But yeah, interesting, I guess, to kind of think about that. Now, in borderline personality disorder, there's no requirement there for a trauma history. It's common, again, 80% or so, but it's not required for the diagnosis. But we do see emotion dysregulation, which is that, again, that affect instability, sometimes more impulsivity. But again, these overlaps go across all relationship difficulties. So similar with CPTSD, identity disturbance, which is similar to negative self-concept, chronic feeling of emptiness and an unstable sense of identity. And stress-related cognitive symptoms, so paranoia, dissociation at times of distress that then resolve when the distress goes down. And you can see there's lots of overlaps here. And we all know people don't fit in perfect little diagnostic boxes, right? Let's have a look at a little closer at what the diagnostic manuals say about what constitutes trauma, because also the definition of trauma can sometimes be very broad. Interestingly, in the diagnostic manuals, it's actually very specific. So in both diagnostic manuals, the DSM-5 and the ICD, they categorize trauma as like big T. Okay. Again, an interesting thing to ponder. So in the DSM-5, what they consider trauma is that exposure to actual or threatened death, serious injury, or sexual violence. And so they categorize either direct experiencing, witnessing it happening to others, learning about a close family member or friend, or repeated exposure, paramedics, police officers, people like that. Okay. So that is how they define trauma. Okay. They do not recognize in the DSM-5 exposure through media, television, movies, pictures, anything like that. So it's a direct experience, or you are very close to somebody who has a direct experience. The ICD, they talk about trauma. And so this is the document that recognizes complex PTSD. The DSM-5 doesn't, the ICD does. They characterize trauma as extremely threatening or horrific in nature, most commonly prolonged or repetitive events where escape was difficult or impossible. And examples that they give are torture, concentration camps, slavery, genocide, prolonged domestic violence, repeated childhood sexual abuse. You can see these are all big T, right? And with BPD, trauma history is common but not required. Again, the studies are showing anywhere between 30 and 90% of people with BPD have a trauma history. The wide variety of that number is because of the definitions of trauma. So if you take into account little t, right? Now, what do we mean by little t? We mean things like lack of emotional connection and validation, right? But if you define it as big T, abuse, then, your numbers sort of change a little bit. But overall, I think most of us in the industry would accept probably 80% of people with BPD have a big T trauma in their history, most commonly childhood sexual abuse. Some of the studies into BPD define trauma as other things, though. So we need to be mindful of like, what is the definition if we're considering that? So childhood trauma is very common in BPD. However, the vast majority of people who experience trauma don't develop BPD. which is interesting, right? And there are certainly people with BPD who have little or no trauma history. I certainly have worked with plenty of those. And so then the question is, so if all BPD is trauma, then what about those people that don't have trauma histories? Now, some people will say, well, maybe it's not remembered trauma, blah, blah, blah. That's a whole rabbit hole. But we do have to acknowledge there are certainly people with BPD who don't have trauma histories. So what's interesting about this is, I guess, the diagnostic criteria around PTSD and complex PTSD are still officially very much focused and limited to big T traumas. Okay. There isn't an acknowledgement in those manuals about, I guess, more subtle, or in DBT would call it corrosive invalidation. So a lack of emotional, connection from parents, a lack of emotional validation, things like that aren't really acknowledged as trauma in the official manuals. There are plenty of studies showing that a lack of emotional validation does have a big impact on children, but that is not recognized as trauma in the official diagnoses for PTSD or complex trauma. Let's think about borderline personality disorder and I guess the predominant theory on how does somebody develop this? So the dominant theory is sort of Marsha Linehan's biosocial model. So this suggests that somebody has a biological predisposition that they are born with, and then they meet what she calls an invalidating environment. She doesn't use the word trauma, right? She uses the term invalidating environment that covers a range of things. So what she's saying here is that for BPD to manifest, there's a biological predisposition that somebody's born with, and then there's also the environmental factors, and it's both are required to develop BPD. So what is this biological predisposition she's talking about? So she's talking about emotional sensitivity, high emotional reactivity, a slow return to baseline. So people are triggered, and it takes them a long time to come back down. And she's referring to studies in babies and very young children that show different levels of emotional sensitivity and different levels of returning to baseline following triggers. We can see in very, very young children differences in their sensitivity levels, which suggests structural and functional brain differences. And I know I've worked with a lot of people with BPD diagnosis who have said, I have always felt things more intensely than other people. And the flip side is they feel love, connection, empathy very, very deeply, but they also feel hurt and pain very, very deeply, which is why it's harder for them to regulate emotions. So this certainly fits with what I hear through people's lived experience, that they have always felt, not everybody, but a good proportion of people with BPD saying they've always felt they were emotionally sensitive. But then we have to take into account the invalidating environment. So this can be trauma, abuse, and it often is, but it can also be things like discouragement of emotional expression, poor modeling of emotion regulation by parents and caregivers. So it can be caregivers that don't express emotions at all, or caregivers that really struggle to regulate themselves, or sometimes there's one of each, which is really hard. And identity and validation. So these are just examples, again, of this sort of invalidating environment. It may be trauma, but it may not be. And so Linehan suggests that it's the combination of these two that produce BPD. Now, what's interesting to think about too is that childhood, by definition, is invalidating. Right? There are times where we don't get our needs met, or where we get discouraged or teased, or, different things. So what she's suggesting is that for a lot of people, that can be hurtful, but it doesn't necessarily develop into BPD if they don't have the biological predisposition and that sensitivity there already. So these are all just theories, right? Can't prove it, but that's certainly kind of the predominant theory at the moment. So back to the question, is all BPD complex trauma? So based on the current research, the answer to that, looks to be no, based on the current research. Now, of course, this can change. There's definitely overlapping symptomology. And again, the majority of people with BPD do have trauma histories, but trauma doesn't account for all people with BPD. Um, so are they the same? Probably not. However, because the majority of people with BPD have trauma histories, we have to treat BPD through a trauma lens, don't we? Right? We can't say, okay, well, you do your trauma treatment over here and your BPD treatment over here. All treatment for BPD must have trauma at the center of its informed approaches. And all BPD treatment needs to be safe and suitable for people with a range of trauma histories. Yeah. So if we're doing that, we're kind of meeting all of the needs. Treatment for BPD needs to have a relational base. And that's because both BPD and complex PTSD, both of these conditions struggle with relationships and sense of identity, right? And so that's where the therapeutic relationship becomes really, really essential. I certainly have found, you cannot treat people with trauma or BPD with this neutral affect, right? They perceive that as like very, very invalidating. So you can't be like totally detached and clinical and do effective treatment with this client base. You need to have warmth, you need to have relational focus, and you need to be able to build trust in the therapeutic relationship before anything else is going to work. And sometimes that can take a long time, particularly if people have a trauma that is an interpersonal trauma, so they've been hurt by people. It takes longer. Both BPD and complex trauma require emotion regulation skills training because, again, these are core components that affect difficulties, go across both. And both require interpersonal effectiveness skills training because, again, relationships are difficult in both. So this is good news. We don't have to take completely different approaches. And both BPD and complex trauma can benefit from distress tolerance skills. We might see problem behaviors in both of these groups, in standard PTSD too, but maybe in BPD and complex trauma, those problem behaviors are more chronic and they can be, suicidality, self-harm, things like that, where we need distress tolerance skills in order to reduce those behaviors. And that is often the priority when people first get into treatment. So I'm going to suggest to you that we kind of have a bit of a flexible viewpoint here. We need to recognize that diagnosis is not an exact science, so we always want to hold it lightly. I've had plenty of clients who have found a diagnosis of BPD or complex trauma quite helpful at explaining their experiences, and that's great. And I've had others that are like, I don't think that fits for me. So don't worry about it, right? So asking those questions of the client, if they do have a diagnosis, how does that fit with them? What do they understand about it? Is it helpful? And if they're not sure or it's not particularly helpful, just hold it really lightly, right? And I always like to say to people, it's not an exact science. Sometimes BPD is a little bit of a diagnosis of exclusion. It's like, well, it's not depression and it's not anxiety and it's not this and it's not this, so it's probably BPD. And if there's trauma, then we might throw in CPTSD there too. So always just checking in with the client about how do they sit with diagnosis and understanding that we have diagnosis as a way to try to communicate symptoms quickly, but it is not an exact science. And even if it was, even if you look at the diagnostic criteria for BPD, if you took all of the different combinations of all of those different symptoms that are in there, you'd be looking at over 200 different variations of BPD. So it doesn't even really tell you very much when someone says, oh, BPD, we might have ideas of what that means, but really until we talk to the client, we probably don't actually know. So Holding diagnosis loosely, but if it's helpful for the client, if it helps them to understand that other people struggle too, and that they're not alone in it, it's not just that they're bad people, this is actually something that people struggle with, then that might be helpful. And always be open to changing our opinion, right? So somebody might come in with a certain diagnosis and we work with them for a while and we might start to see things differently. Or we might find somebody starts to respond very well to treatment or not respond well to treatment. And then we need to go back and say, like, what might be we be missing here? Or why isn't this working? And take, stay open to changing our mind. We always want to review treatment efficacy. So I would say, like, if you've been treating somebody for a year and they're not getting any better, we're missing something, right? Even if it's slow progress, that in that period of time, something should be shifting. Otherwise, maybe we are not using the right model for that person, or there's something else that we're missing. Yeah. So 12 months of treatment with no change, in my experience, would be a reason to go back to the drawing board and look again. Okay, we'll get our nerd on a little bit here. I know you guys love research. So in regards to, all right, treatments for PTSD, complex trauma, and BPD. So let's have I've just cherry picked a few little things. So for PTSD, we've got some good evidence around DBT-PE. So this is dialectical behavioral therapy, prolonged exposure. Okay, so this is standard DBT plus prolonged exposure trauma treatment. Okay, so this is a model that's being studied more and more. This RCT showed higher efficacy in treating people with straight PTSD. DBT prolonged exposure had double the efficacy of standard DBT. Now, what they did find was that doing staged treatment was really important. So stage 1 was standard DBT still. And I'm going to strongly argue that most of the time, particularly if you're dealing with risky behaviors or chronic behaviors, you're going to want to start with a standard DBT type of approach just to get safety and stabilization and skills on board. But then stage 2, they moved into prolonged exposure. So this was more in-depth trauma work, and people seem to respond well in this randomized control trial. So, yeah, less suicide attempts, less self-injury. It was a small sample though, so there needs to be more research around this particular type of model. So clients generally did 20 weeks of standard DBT first before they went into DBT prolonged exposure. Now that 20 weeks was 2-hour skills group, 1-hour individual therapy, and access to phone coaching. So it was an intense 20 weeks before they were ready for prolonged exposure. So if you were doing less intensity, you'd probably want to drag that out. And I certainly, like with my clients, would do stage 1 until things were safe and stable before thinking about doing any trauma work with them where we're intentionally bringing up trauma memories for processing. If we have a look at complex PTSD, so there's another adaptation to DBT, which they're calling DBT PTSD. This has shown some good impact again in randomized controlled trial. So this is basically DBT plus cognitive processing therapy. So this is where they challenge some of the cognitive distortions associated with trauma. So it can be things around self-blame. It can be around, well, I can never, nobody's ever safe because this person wasn't safe. A lot of those sorts of beliefs that come out of the trauma, they target through cognitive processing therapy. Again, in a phased approach. on its own, cognitive processing therapy did not perform as well as when it was combined with DBT for complex trauma, which is interesting. So the DBT element does seem to make it much more effective. This was a fairly large study. It went over 15 months, 193 participants. Um, and yeah, so they got quite a lot of input, 45 individual sessions, phone support, and some follow-up. So dropout rates were lower um, with DBT PTSD than standard DBT for this group, which, yeah, again, is interesting. There's a graph that's just the same thing I just explained. So remission rates and that sort of thing. So overall, the evidence, now we know that the evidence base for borderline personality disorder is DBT, right? So that's still considered the most effective treatment for borderline personality disorder. But when we start to mix in PTSD and complex PTSD, is that still the case? It certainly looks that DBT plus seems to have the best evidence base for these conditions. So for PTSD and borderline personality disorder, again, that DBT plus prolonged exposure is looking pretty promising. DBT PTSD seems great for that complex trauma, childhood abuse stuff. And yeah, overall PTSD symptoms can be reduced through a lot of these methods. So DBT plus other things. But it seems that DBT, having that as part of the treatment model, particularly as stage one, still gets the best outcomes. So as it says down here, regardless of whether a client meets criteria for BPD, PTSD, or complex PTSD, treatments that directly target emotion dysregulation appear to improve outcomes. So DBT-based approaches, because they target emotion dysregulation as the core issue, seem to have benefits for BPD, PTSD, and complex PTSD, but maybe with some adaptations along the way in stage two. So what does this all mean? A staged approach to treatment is going to be really, really important. And I would say this is really important too, just because of safety. So clients with BPD, PTSD, or complex PTSD can be harder to treat. It takes longer. Some of the issues can be quite ingrained and chronic, and they can also display very risky behaviors, and they can be high risk for suicide, right? We know that. So we have to keep safety absolutely at the core of whatever our treatment approach is. But we can't just stop at safety, right? We know that just case management and crisis management for these clients does not work well either. So we need to keep safety as key, but we also need to have a plan to progress the treatment as things stabilize, right? So people can actually get better long term and it's not just a band-aid type fix. So distress tolerance and emotion regulation skills, these really have to be the priority. These are the things that help people stay alive and help people stay safe. If people can't manage their times of intense distress, they're going to continue to be risky. So we have to teach distress tolerance and emotion reg. And again, I mean, I come from a DBT background, so that's what we do. If we do trauma work prematurely, we can actually make things worse, right? So if I take my client who comes in to see me, let's say they present with a complex PTSD diagnosis, they come to see me and I go straight into trauma exposure work. That's very, very risky because they're already struggling just to get through the day, right? And I know it might sound crazy to some people of like, why would you do trauma work off the bat? There's plenty of models that session one, they're in there. I've spoken to very experienced clinicians who are like, we attack the trauma session one, regardless of the diagnosis. I find that a little scary. So I wouldn't recommend that. I think distress tolerance and emotion reg, always. Have a look at what are the problem behaviors, what are the avoidance behaviors. We need to get those to reduce so people are actually able to feel their feelings. If I'm then going to do trauma work, we need to be able to do that with somebody who is able to actually handle what's going to come up in that, right? If they're just treading water and they're trying to stay alive day to day, and you do trauma work, you're going to send them out into the world having to avoid more because you've really bumped up their distress. I'm going to explain a little bit more about that in a minute. So initially, I would suggest to you that whether it's BPD, CPTSD, or PTSD, you do the same treatment plan to start with, which is distress tolerance and emotion reg. If you are not DBT trained, those would be my priorities at upskilling in those areas. So we've got in distress tolerance, crisis skills, somatic skills, settling nervous system, all those things to get through intense distress without having to engage in problem behaviors. And then emotion regulation is really about befriending emotions and learning to name, sit, and be with rather than avoid emotions. And this is what increases people's capacity to then go on and do trauma work more safely. So I'd always start there. And stage one, this could and should be probably like 1 to 2 years. It's a really long time. So we focus on safety, emotional literacy. A lot of clients struggle even just to name their emotions. We want to build that before we do trauma work. Again, distress tolerance skills, getting through times of emotional crisis, emotion reg, interpersonal effectiveness. People are most often the trigger. So how is that playing out for the client? What interpersonal skills do they need to manage that? Can we build in some mindfulness? Clients who come in crisis are often really avoidant of mindfulness. I don't teach mindfulness first, which is how in traditional DBT it's taught. I actually teach it last because I just find it is very hard for people to sit with, and they need to build up skills to be able to do that. So stage one, again, the recommendations are really like 1 to 2 years of stage one. So upskilling, stabilizing, getting people really literate and really able and confident to sit with distress. And then stage two, once risky behaviors and avoidance behaviors have settled down, that tells you that they might be ready. If it's complex PTSD or PTSD, maybe then we switch into more trauma-focused treatments, graded exposure, maybe, prolonged exposure, some of those models. EMDR might fit in here, even schema. Schema is not technically a trauma therapy, but it does require a level of stability. You could certainly introduce it in stage one, but I would think clients would get more out of it in stage two when the crisis has settled. So just to dive a little deeper into that, this is how I think about, staging our interventions. So there's 2 factors that are really, really vital to understanding where the client is at. So one factor is how much emotional pain or distress is this client experiencing in their life at the moment? And what is their level of distress tolerance? How much distress can they handle before they start avoiding and doing problem behaviors? Self-harm, suicidality, substance abuse, all of them, right? So this client in front of us here has pretty low levels of emotional distress and pain and pretty high levels of distress tolerance. This client's doing well. This is the kind of client who's not coming in crisis. Maybe they're coming in because they're having a problem in their relationship that they want to talk through, or I don't know, they're at a crossroads at work or something, right? But they're not in crisis. You're not seeing problem behaviors and avoidance behaviors all over the place, right? So this person doing pretty well. As soon as this relationship changes, okay, as soon as this person now has pretty high levels of emotional distress and pain, and notice their level of distress tolerance is actually pretty low, lowish. Okay, as soon as pain is higher than ability to tolerate pain, this is crisis. You're going to be seeing lots of avoidance behaviors, lots of risky behaviors, lots of crises, lots of overwhelm, lots of dysfunction, right? All that's telling you is that this person's pain is higher than their capacity to handle that pain. And there's reasons why people might have lower distress tolerance, not their fault at all. But again, if we go with the theory that some people are born more emotionally sensitive, they might actually have lower levels of distress tolerance. Or if they've experienced, lots of invalidation and lots of stuff like that, that might lower their distress tolerance. If they've been doing a lot of avoiding for a long time, that's going to lower their distress tolerance. So lots of things can make that go down before they get anywhere near us. Now, this person's also in crisis. So this person has very high levels of pain and distress. They actually have pretty high levels of distress tolerance, but it's not high enough. This person is still in crisis. Most of the time, maybe they were coping, but something happened and it tipped the pain higher, and now they're in crisis. And it looks the same as this. Now, this person has very low distress tolerance, and objectively, they don't have a ton of pain in their life, but they are still in crisis, right? Because as soon pain is higher than tolerance, we're going to go into crisis mode, lots of avoiding, lots of chaos and problem behaviors. So it's not the level of pain that determines what's happening. It's the relationship between pain and pain tolerance. We get that? So we can do two things. We can try and bring down pain, okay? Because if I can get pain lower than pain tolerance, my client's going to be doing much better. But it can take a really long time to bring down pain, and sometimes we just can't. You have clients who are still living in environments where there's a lot of invalidation or even abuse. You have clients who, maybe they have unstable accommodation or, all sorts of things that we can't necessarily bring down pain, or we certainly can't do it quickly. But, what we can do pretty quickly is we can bump up distress tolerance, okay? So if I do nothing with that pain, but I increase my client's tolerance to pain, they're going to be doing better. Even if I don't go anywhere near reducing the pain, right? They're going to be doing better. And we know how to do this. This is psychological skills training, right? This is basically DBT skills of we're building tolerance to difficult emotions using skills. In an ideal world, we'll do this, right? In an ideal world, the client is with us for long enough where we can, build up skills to tolerate pain, and over time, we can gradually bring down pain too, right? And this is where long-term things, start to go a lot better. But if we only have a short amount of time, maybe we can just do this. Or certainly in the beginning, if we can't do this, we can do this first, right? And then we can start to lower this. Much safer, much more effective. And that's the staged approach. Stage 1, stage 2, right? And then, ideally we can do both. So in summary, we know that BPD and complex trauma have a really high rate of correlation. However, BPD does still seem to be a diagnosis of its own, where not everybody with BPD has complex trauma, okay? But there is a high correlation. We've talked about stage approaches, much safer, and I would argue more effective. Clients are more likely to stay in for longer if we take that staged approach of first increasing skills and then working on the pain. And we also want to acknowledge stigma, right? So we know, particularly with BPD, there is a very decades-long history of really, really bad stigma. And when people are coming to see you and they have this diagnosis on their file, we have to assume that they have had negative experiences with help seeking. Most of them have. And so we're going to be triggers for them when they come to seek help. So we're going to need to work more on relationship, trust, unconditional positive regard, and, talking to them openly about the treatment plan and the treatment goals. So we may have to allow more time or more focus on building that trust before we can even get into any sort of, therapeutic model. All right, there's my details if anyone wants to reach out to me up there. Does anybody have questions or comments? I know that's a lot of info for you. Tell me your thoughts. You can do in the chat, or you can just take yourself off mute if you've got questions or comments, or yeah, something you want to say. Go for it.
I think you explained that really well. Like I really like the how you explain the stages. Yeah, it just made it really click how you explain that. So thanks.
Oh, good. Thanks, Corinne. Appreciate that. Other comments, questions? Yeah, buts can be a tricky area. Well, it is a tricky area. Okay. Well, if there's no other questions or comments, feel free to, oh, hang on, got someone in the chat. Oh, thank you. Thanks, Zara. I hope I'm saying that right. Thank you very much. Yeah, it is a topic that's being talked about more and more. Bianca. Oh, great. Thanks, Bianca. I appreciate that. Yeah, it's a topic that's being talked about more and more, and I think it'll be interesting to see when the new DSM comes out. Who knows when that will be? The DSM-6, once they do that, it'll be interesting to see what happens. There was talk for the DSM-5 about getting rid of borderline personality disorder as a diagnosis and changing it to something else. There was some affect regulation disorder was bandied around, emotion sensitivity disorder was bandied around, but they ended up sticking with borderline personality disorder. Um, so it'll be interesting to see in the DSM reviews if any of that changes. It'll be interesting to see whether complex PTSD makes it into the DSM in the next iteration as well, given that the World Health Organization has acknowledged it as its own disorder. So yes, we'll see what happens. But I think for those of us, you're working in this area, you're seeing, how things actually present and yeah, these questions around the overlaps and then does that change our approach, right? And that's the important question. It's less important what the diagnosis is and it's more important of how does this inform my treatment plan. And the good news is because there's a lot of overlap here, if we take that approach of staged treatment, building up skills, we'll be on the right track for people. And clients are less likely to drop out and become overwhelmed, I think, when we take that approach too. So if you guys are interested in any other DBT training or resources, please feel free to drop me a line. If you're not already in my Facebook group, DBT for Helping Professionals, make sure you jump in there because there's lots of resources, free resources and recordings and things in there. It's the one with Kermit sitting on the couch in the picture. You can look it up, DBT for Helping Professionals. Lots of free stuff in there. But yeah, feel free to reach out to me if you have any questions or you want to chat more. And I appreciate you all being here. Great to connect. I will see you all next time. Bye.